Welcome to Endocrine Part 2. This lecture is about the parathyroid and adrenal glands.
Please note the parathyroid glands are four glands that sit on the posterior thyroid gland. Parathyroid hormone regulates calcium and phosphorus balance. Increased parathyroid hormone elevates blood calcium by increasing calcium absorption from the kidneys, intestines, and bone. Parathyroid hormone lowers phosphorus level.
Milder cases of hyperparathyroidism show symptoms such as fatigue, muscle weakness, depression, body aches. Severe symptoms include loss of appetite, constipation, vomiting and nausea, excessive thirst and urination, confusion and memory loss, and kidney stones. Primary hyperparathyroidism is 2 times to 4 times more frequent in women. Manifestations include elevated serum calcium, bone decalcification, renal caliculi, apathy, fatigue, muscle weakness, nausea, vomiting, constipation, hypertension, cardiac dysrhythmias, and psychological manifestations. This condition of excessive calcium in the blood, called hypercalcemia, is what usually signals the doctor that something may be wrong with the parathyroid gland. In 85% of people with primary hyperparathyroidism, a benign tumor called an adenoma has formed on one of the parathyroid glands, causing it to become overactive. Benign tumors are non-cancerous. In most other cases, the excess hormone comes from 2 or more enlarged parathyroid glands, a condition called hyperplasia. Very rarely, hyperparathyroidism is caused by cancer of a parathyroid gland. Question: which of the following hormones regulates serum calcium level? Thyroid stimulating hormone, parathyroid hormone, insulin, or oxytocin? Think about your answer. Reiterate, the signs and symptoms of hyperparathyroidism include kidney stones, aches, pains, depression, and fatigue. The preferred treatment is removal of parathyroid tissue. Most likely it is related to an adenoma. Parathyroidism is caused by abnormal parathyroid development, destruction of the parathyroid gland, autoimmune response, and vitamin D deficiency. The most common cause is the near total removal of the thyroid gland. The result is inadequate secretion of parathyroid hormone. The diagnosis of hypoparathyroidism often is difficult because of the vague symptoms such as aches and pains. Hypoparathyroidism is an uncommon condition in which your body secretes abnormally low levels of parathyroid hormone. Parathyroid hormone is key to regulating and maintaining a balance of the body's levels of 2 important minerals, calcium and phosphorus. The low production of PTH in hypoparathyroidism leads to abnormally low calcium levels in the blood and bones and to an increase of phosphorus in the blood. Supplements to normalize your calcium and phosphorus levels treat this condition. Shivastics, Trousseau's, and Tetany. 3 important assessment and diagnostic findings to be aware of in the patient with hypoparathyroidism. Shivastic sign is positive when a sharp tapping over the facial nerve causes spasm. Trousseau sign is positive when a carpopedial spasm is induced by occluding the blood flow to the arm for about 3 minutes with a blood pressure cuff. Tetany develops at very low serum calcium levels. The management of hypocalcemia depends upon the severity of symptoms. In patients with acute symptomatic hypocalcemia, IV calcium gluconate is the preferred therapy, whereas for chronic hypocalcemia, oral supplements such as coral calcium or calcium citrate are preferred, and increased ingestion through the diet, either through dairy products or nuts or green leafy vegetables if dairy is not well tolerated. The management of hypocalcemia depends upon the severity of symptoms. In patients with acute symptomatic hypocalcemia, IV calcium gluconate is the preferred therapy, whereas for chronic hypocalcemia, oral supplements such as coral calcium or calcium citrate are preferred, and increased ingestion through the diet, either through dairy products, or nuts or green leafy vegetables if dairy is not well tolerated. Hypocalcemia and anticipating signs of tetany, seizures, and respiratory difficulties. Calcium gluconate should be available for emergency IV administration. Now we're going to start talking about the adrenal glands. The adrenal glands are responsible for managing stress, regulating blood pressure, and balancing water and salt levels. Now let's talk about the hormones that the adrenal gland produces. The adrenal cortex produces hydrocortisone, corticosterone, aldosterone, sex hormones. The adrenal medulla produces epinephrine and norepinephrine. These hormones regulate many of our internal processes throughout the day. Now we're going to begin to talk about the adrenal medulla. About 90% of the secretion of the human adrenal medulla is epinephrine, also called adrenaline. Catecholamines regulate metabolic pathways to promote catabolism of stored fuels to meet caloric needs from endogenous sources. The major effects of epinephrine release are to prepare to meet a challenge, such as the flight or fight response. Secretion of epinephrine causes decreased blood flow to tissues that are not needed in emergency situations, such as the GI tract, and increased blood flow to tissues that are important for effective fight or flight responses, such as cardiac and skeletal muscle. Catecholamines also induce the release of free fatty acids, increase the basal metabolic rate, and elevate the blood glucose level. Now let's talk about the adrenal cortex. The three types of steroid hormones produced here are glucocorticoids, mainly cortisol, mineralocorticoids, mainly aldosterone, and sex hormones, mainly androgens, male sex hormones. Survival in the absence of a functioning adrenal cortex is possible only with nutritional, electrolyte, and fluid replacement and appropriate replacement with exogenous adrenocortical hormones.
The glucocorticoids are named so because they have an important influence on glucose metabolism. Increased cortisol secretion results in elevated blood glucose levels. However, the glucocorticoids have major effects on the metabolism of almost all organs of the body. Glucocorticoids are secreted from the adrenal cortex in response to the release of ACTH from the anterior lobe of the pituitary gland. The system represents an example of negative feedback. The presence of the glucocorticoids in the blood inhibits the release of CRH from the hypothalamus and also inhibits ACTH secretion from the pituitary. The resultant decrease in ACTH secretion causes diminished release of the glucocorticoids from the adrenal cortex. Steroids are drugs that are administered to inhibit the inflammatory response to tissue injury and to suppress allergic manifestations. Their side effects include the development of diabetes, type 2, osteoporosis, peptic ulcer disease, increased protein breakdown resulting in muscle wasting and poor wound healing, and redistribution of body fat. When large doses of glucocorticoids are administered, the release of ACTH and endogenous glucocorticoids are inhibited. This can cause the adrenal cortex to atrophy. If exogenous glucocorticoid administration is discontinued abruptly, adrenal insufficiency results because of the inability of the atrophied cortex to respond adequately. Mineralocorticoids exert their major effects on electrolyte metabolism. They act principally on the renal, tubular, and GI epithelium to cause increased sodium ion absorption in exchange for excretion of potassium or hydrogen ions. ACTH only minimally influences aldosterone secretion. It is primarily secreted in response to the presence of angiotensin II in the bloodstream. Angiotensin II is a substance that elevates the blood pressure by constricting arterioles. Its concentration is increased when renin is released from the kidney in response to decreased perfusion pressure. The resultant increased aldosterone levels promote sodium reabsorption by the kidney and the GI tract, which tends to restore blood pressure to normal. The release of aldosterone is also increased by hyperkalemia. Aldosterone is the main hormone for the long-term regulation of sodium balance. The adrenal gland may also secrete small amounts of some estrogens or female sex hormones. ACTH controls the secretion of adrenal androgens. When secreted in excess, they produce masculization in women, feminization in men, or premature sexual development in children. This is called the adrenogenital syndrome. The two major adrenal disorders we're going to discuss are primary adrenal cortical insufficiency, lack of cortisol, a disease called Addison's disease, or excessive adrenal cortex activity, i.e. Cushing's syndrome. Autoimmune polyendocrine syndrome. Primary adrenal insufficiency develops in childhood. Signs and symptoms of Addison's are apparent. Hypoparathyroidism, delayed sexual development, vitamin B12 deficiency, candidiasis, possible hepatitis. If APS2 symptoms develop in the 18 to 30 age group, the continued expression of Addison's, thyroid disorders, diabetes, celiac disease, vitiligo, and delayed sexual development occurs. Let's think about the adrenal glands and their essential bodily functions. For example, they work with other endocrine glands to modulate inflammation, carbohydrate metabolism, body composition, and sleep and wake cycles. A pheochromocytoma is a rare, usually non-cancerous benign tumor that develops in an adrenal gland. Usually, this type of tumor affects one of the adrenal glands, but it can affect both. If a pheochromocytoma is noted, the tumor releases hormones that cause either episodic or persistent high blood pressure. The big concern with pheochromocytoma is adrenal crisis. What is adrenal crisis? A sudden large increase in adrenal hormones. These hormones cause severe high blood pressure and tachycardia. Some of the common symptoms are sudden onset of severe headaches, sweating, abdominal pain, increased palpitations, high blood pressure that may be resistant to conventional medications, irritability, anxiety, hypoxia. Some common causes of adrenal crisis are corticosteroids, chemotherapy agents, surgical anesthesia, and some street drugs such as cocaine. Pheochromocytoma is suspected if signs of sympathetic nervous system overactivity occur and associated with marked elevation of blood pressure. These signs can be associated with the 5 H's: hypertension, headache, hyperhidrosis, hypermetabolism, and hyperglycemia. The presence of these signs is highly predictive of pheochromocytoma. Paroxysmal symptoms of pheochromocytoma commonly develop in the 5th decade of life. Lab assessments of pheochromocytoma include measurements of urine and plasma levels of catecholamines, Endocrine, a catecholamine metabolite. These are the most direct and conclusive tests for overactivity of the adrenal medulla. Pharmacological management of the hypertension associated with pheochromocytoma includes the use of alpha blockers, beta blockers, and calcium channel blockers to control the blood pressure. Now we're going to talk about Addison's disease, also considered primary adrenal insufficiency. Some of the signs and symptoms include muscle weakness, anorexia, fatigue, emaciation, dark pigmentation of the mucous membranes and the skin, especially of the knuckles, knees, and elbows, hypotension, hypoglycemia, low serum sodium, and high serum potassium. In order to make the diagnosis of Addison's disease, combined measurements of early morning serum cortisol and plasma ACTH are performed to differentiate primary adrenal insufficiency from secondary adrenal insufficiency and to differentiate from normal adrenal function. Patients with primary adrenal insufficiency have a greatly increased plasma ACTH level and a serum cortisol concentration lower than the normal range or in the low normal range. Other laboratory findings include decreased levels of blood glucose, and decreased levels of sodium, hyponatremia, an increased serum potassium concentration, and an increased WBC concentration. Immediate treatment of Addisonian crisis is directed towards treating circulatory shock, restoring blood circulation, administering fluids and corticosteroids, monitoring vital signs, administering hydrocortisone, Solucortef by IV, followed by D5NS. Vasopressors may be indicated if the hypertension is persistent and unresponsive to fluid challenges. Lifelong management of the patient with Addison's disease includes replacement with corticosteroids and mineral corticosteroids to focus on the prevention of the reoccurrence of adrenal insufficiency, particularly during stressful procedures or significant illnesses. Additional supplemental therapy with glucocorticosteroids is required to prevent full-blown Addisonian crisis. In addition, the patient may need to supplement dietary intake with salt during episodes of illness, particularly GI illness that would include vomiting and diarrhea. Nursing management of the patient with Addison's exacerbation includes vital signs, orthostatics, skin assessment, a focus on restoring fluid balance, education regarding triggers and prevention of full-blown Addisonian crisis. Notice the pictorial representation of all the side effects of Addison's disease: the bronzed skin, the hypotension, the hypoglycemia, GI disturbances, weakness, the ability to go into profound Addisonian crisis. Remember, Addisonian crisis is acute adrenocortical insufficiency. It is characterized by severe hypotension, cyanosis, fever, nausea, vomiting, and classic signs and symptoms of shock. The patient with Addisonian crisis requires immediate treatment with IV administration of fluids, glucose, electrolytes, especially sodium, replacement of missing steroid hormones, and vasopressors if the patient is severely hypotensive. Now we're going to talk about Cushing's syndrome. So Cushing's syndrome is the direct opposite of the Addison's disease. It results from excessive rather than deficient adrenocortical activity. Increased corticosteroid production secondary to hyperplasia of the adrenal cortex is one of the main reasons for Cushing's syndrome. Now we're going to talk about Cushing's syndrome. So Cushing's syndrome is the direct opposite of the Addison's disease. It results from excessive rather than deficient adrenocortical activity. Increased corticosteroid production secondary to hyperplasia of the adrenal cortex is one of the main reasons for Cushing's syndrome. This is just a slide speaking about the possible causes of Cushing's syndrome previously articulated, such as pituitary tumors and adrenal tumors. The classic picture of the adult with Cushing's is central type obesity with a fatty buffalo hump in the neck and supraclavicular areas, a heavy trunk, and relatively thin extremities. The skin is thin, fragile, and easily traumatized. Ecchymosis abounds, and striae develop. The patient complains of weakness and lassitude. Sleep is disturbed because of altered diurnal secretion of cortisol. The 3 tests used to diagnose Cushing's syndrome include serum cortisol, urinary cortisol, low-dose dexamethasone suppression tests. 2 of these 3 tests need to be unequivocally abnormal to diagnose Cushing's syndrome. This is a mnemonic to help you remember the signs and symptoms of Cushing's syndrome. C for central obesity. U for increased urinary free cortisol. S for the striae that form. H for the hypertension, hyperglycemia, hypocholesteremia, high cortical state that occurs with Cushing's syndrome. I. Possible cause being increased administration of steroids. N. Another possible cause, neoplasm. G. Glucose intolerance that occurs along with Cushing's syndrome. This slide is just a little cartoon highlighting some of the side effects of Cushing's syndrome, such as personality change, moon face, the client is immunocompromised, sodium and fluid retention, thin extremities, hyperglycemia, just to name a few. Surgical management of Cushing's syndrome includes surgical removal of pituitary tumors, adrenal tumors. Radiation of the pituitary gland also has been successful, although it may take several months for control of symptoms. Adrenalectomy is another potential surgical procedure, and it might be the treatment of choice in patients with primary adrenal hypertrophy. This is a slide talking about adrenal fatigue. Many factors affect the adrenal glands, such as life stress, such as financial stress, poor lifestyle choices, such as smoking, increased ingestion of alcohol, drugs, poor eating habits, increased amounts of caffeine, sugar. So we must think about ways in which we can combat this stress and keep our adrenals healthy by participating in different lifestyle choices such as meditation, exercise, yoga, things that'll slow down our response to stress and help us to live a healthier lifestyle. This ends the Endocrine Part 2 lecture.